30 seconds, sir?
Yes, sir.
Okay, okay. A very good evening to all of you. We welcome you back to this online course on oculoplastics by Subramaniam sir. So this week in the sessions we have taken a break and we have a case presentation from Dr. Amulya, who is a third year postgraduate from Regional Eye Hospital Vizag. So she'll be presenting a case of thyroid eye disease, and Subramaniam sir will be moderating this case along with giving useful inputs to all the PGs. I hope this case presentation would be a refreshing to your knowledge. And from next week, we'll continue the course as per the schedule. Now I hand over the podium to Amulya, and I also welcome Meenakshi Madam, the HOD of REH Vizag, along with other faculty from Vizag. So Amulya,
Good
you
evening,
can.
everyone.
Yeah.
Good evening, sir, Subramaniam sir, and good evening, Madhu.
Good evening, madam.
Good evening, madam.
Yeah. I think Amulya, can you start presenting the case now?
Yes, sir. Yes, sir.
Okay.
Good evening, all the respected sirs and ma'ams. Today I'm going to present a case on the thyroid eye disease. So here are my patient details. So he's Mr. Ishwar Rao, a 37-year-old male who is a shopkeeper by occupation, hailing from Madilpalam, Visakhapatnam, who is presented to us with a chief complaint of prominence of both eyes since 8 months, whereas right eye is greater than the left eye.
Okay, Amulya, am I audible?
Yes, sir. Yes, sir.
Right, very good. What is the importance of the gender male in this case?
So, basically, history of smoking is very much common in male gender.
Hey, just I'm asking the gender, not whether he is a smoker or not. All males are not smokers, right? I'm a non-smoker.
Yes, sir.
What is the importance of gender male in thyroid? Because you said that it's case of thyroid arthritis.
Yes, sir. Yes, sir. Yes, sir. Actually, thyroid is an autoimmune disease, a chronic autoimmune disease, whereas all the autoimmune diseases are having a female preponderance. But this is one of the case where a male presented with a thyroid eye disease.
That's not it. That's not the answer I wanted. What is the most important ophthalmic complication of thyroid eye disease? Is loss of vision due to compressive optic neuropathy, otherwise also known as dysthyroid optic neuropathy. There are 4 important male risk factors for it, major risk factors, and the gender male is one of the most important risk factors. So that is the importance of gender male in a patient of thyroid-associated orbitopathy. Similarly, the age 37, that is in the 4th decade.
Yes, sir.
Right.
Yes,
A
sir.
thyroid orbitopathy occurring in the 4th decade is a risk factor, a major risk factor for optic neuropathy. So Mr. Ishwar Rao, who is a male, 37 years of age, means he has already 2 out of the 4 major risk factors to develop compressive optic neuropathy.
Yes.
Right. A young female rarely develops compressive optic neuropathy, whereas an elderly male is more susceptible to develop optic neuropathy. That is the clinical importance. Okay, go ahead.
So, coming to the history of present illness, patient was asymptomatic till 8 months back when he noticed the prominence of both eyes, where the prominence of right eye is greater than left eye, which was insidious in onset and progressive in nature. The prominence was associated with mild discomfort of both the eyes. There's no history of trauma. There's no history of loss of weight. There's no history of sweating, tremors, or palpitations. There's no history of defective vision or defective color perception. There's no history of hyperpigmentation of lids or eyes. There's no history of postural variation on bending forwards. There's no history of variation with sneezing, coughing, or straining. There's no history of radiation or chemotherapy in the past. There's no history of other swellings in the body. There's no.
What is, okay, 1 minute. Go back to the previous slide if you don't mind, please.
Yeah, yes, sir. Yes.
Right. What is the importance of history of loss of weight?
So particularly in hyperthyroidism, there will be loss of weight, fever. Despite having good appetite, there will be a loss of weight, sir.
Right. Right?
Increased
Despite
metabolic
good,
activity.
yes, increased metabolic activity.
Sir.
So loss of weight, tremors, palpitation all point out towards the systemic status of hyperthyroidism, which is more commonly associated with thyroid orbitopathy. Right?
Yes.
What is the importance of defective vision and defective color perception?
So whether there is an involvement of optic nerve or not during the presentation.
Right. For compressive optic neuropathy.
Yes, sir.
Hyperpigmentation of lids and eyes.
It's one of the feature of hyperthyroidism signs where the pigmentation of the eyelids increases, and also one of the cases of neurofibromatosis, there will be a capillary spots pigmentation on the lids. So
Yeah.
to rule out those conditions, we ask the hyperpigmentation of the lids.
Okay. But capillary spots and neurofibromatosis are usually congenital and you occur much younger in age.
Yes, sir.
After this.
Yes.
Okay. Instead of postural variation. Okay. Others go ahead. Go ahead with it, your presentation. Go ahead.
Yes, sir. Coming to the past history, there's history. The patient has having history of taking tablet carbamazole 5 mg once a day for the past 2 months, and tablet Thyrovel, which is a combination of tyrosine and selenium, for the past 2 months. And he took 9 doses of IV methylprednisolone over a period of 3 months when the disease is active. So this is the second visit, sir, when I took the case. During the first visit, he came to know that there is a thyroid problem. So he went to the KGH and he took all the treatment, and he came back for the second.
It's with the endocrinologist. It was treated by endocrinologist
Yes.
early.
Yes, sir. Yes, sir.
Okay. He was treated for thyroid orbitopathy with IVMP or for any systemic thyroid condition?
Thyroid orbitopathy.
Orbitopathy. Okay. Do you have any dose schedule? How much he was given, at what dose he was given, and all that?
Sure.
Those details are present with you or no?
Yes, sir. He took 9 doses of 500 mg of IV methylprednisolone, sir, once a week.
Once a week. What is that schedule?
Sir, according to European group of
You
Yes,
go classification. Okay.
according to European group of Graves orbitopathy.
Okay. So we'll discuss with them after some time. Right, go ahead.
Okay, sir. There is no history of hypertension, diabetes mellitus, and cardiac disease.
What is the importance of diabetes mellitus? Is it for general routine you have asked, or is there any importance for which it was attached to diabetes mellitus?
Yes, sir.
What is it?
So, if the patient is having any diabetes, so diabetes is basically a comorbidity with increasing age. It will be presented, and they are very prone to infections. So,
for that reason, you asked for diabetes.
Prone to infection.
Okay. No, among the four, the third most important risk factor for compressive optic neuropathy is diabetes mellitus. An elderly male with a recent onset of the hyperthyroidism and a known patient of diabetes has very high risk of developing compressive optic neuropathy. So for thyroid associated orbitopathy, the importance of diabetes mellitus is, apart from the routine infections and blah, 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 these chances of developing compressive optic neuropathy are much higher when compared to a non-diabetic individual. For that reason, you have to know. Okay?
Yes.
Right.
There's no history of any other systemic diseases. There's no history of exposure to radiation, and there is no history of any malignancies. Personally, patient takes mixed diet. Bowel and bladder habits are normal. He's a known alcoholic since he is 20 years old. He drinks occasionally. Sir. The patient is not a known smoker.
What is the importance of not a smoker?
Smoking is the highest, the most risk factor for the progression of the thyroid disease. Sir.
Not only for the progression of thyroid disease, for compressive optic neuropathy. The prevalence of compressive optic neuropathy is 6 to 7 times more in smokers when compared to non-smokers. The 4 major risk factors for the development of compressive optic neuropathy are gender, male, age, elderly, 40 decade and above, diabetes mellitus, and smoker.
Yes.
The only modifiable risk factor is smoking.
Yes.
The other 3 cannot be modified.
Yes.
Right?
Yes.
So that is why for every person, if a person is known to be having thyroid systemic disease, if he is a smoker, his chances of developing thyroid compressive optic neuropathy are 6 times more. Thyroid ophthalmopathy are 6 times more in a smoker when compared to a non-smoker. So even in the absence of thyroid orbitopathy, we have to dissuade the patient, a thyroid patient, not to smoke. If he had optic neuropathy, definitely he should not smoke. Right?
Yes, sir.
What is the incidence or prevalence of thyroid compressive optic neuropathy in TAO? Five to 7%. In a smoker, it becomes about 30 to 50%. Every second or third person who is a smoker will develop optic neuropathy. Okay? Go ahead.
So coming to the family history, there is no history of similar complaints in the family.
Similar complaints in the family means thyroid orbitopathy or thyroid systemic disease you are talking about.
Both.
So you did read that. There is no history of systemic thyroid disease or thyroid orbitopathy in the family.
Yes.
Okay, go ahead.
Coming to the general examination, patient is moderately built and nourished, is conscious and coherent. Pulse rate is 70 beats per minute. Blood pressure is 100 by 70 mercury, mm of mercury. Temperature is febrile. The respiratory rate is 16 breaths per minute. There is no palorectal cyanosis, clubbing, or pedal edema seen. There is no evidence of any regional or general lymphadenopathy. Coming to the neck examination, is revealed mild diffuse thyroid gland enlargement. Respiratory system, there is normal vesicular breath sound head in both lungs on auscultation. Per abdomen was normal with no evidence of any intra-abdominal mass. Coming to the ENT, no evidence of the sinus tenderness is noted.
Okay.
Examination of the central nervous system, there's no signs of...
1 minute. Did you look for the tremors?
Yes.
Where did you mention it? That should be in the general examination only.
Yes.
And also you have to, in the case of thyroid orbitopathy, you have to also look for pedal pretibial myxedema also.
Yes.
That should also come in the general examination.
Yes, sir.
Okay. Those 2 you have to add. You remember that for all the postgraduates, One of the most common cases, long cases, is thyroid-associated orbitopathy, because proptosis will be a long case, and the most common cause of both unilateral as well as bilateral proptosis is
Thyroid.
thyroid. So more often than not, the chances are that you will get a case as a long case of TAO. So you have to read everything. Everything should be on your fingertips.
Yes.
Okay. Go ahead.
So examination of central nervous system, there's no signs of confusion, lethargy or dementia. The motor system is normal, with bulk, tone and power are normal. Cerebellar functions are intact. Superficial reflexes are normal. Deep tendon reflexes are normal. All cranial nerves are normal. There is no evidence of dystiadokinesia. No past pointing test was normal. Coming to the ocular examination, the right eye, the visual acuity, the uncorrected visual acuity is 6/6. The color vision, the patient did 17 out of 17 pairs of Ishihara charts. The eyelids, the upper and lower eyelids are retracted in the right eye. The upper lid is just touching the limbus. The inferior scleral show of 1 mm is present.
1 minute. 1 minute. Here you have to write margin reflex distance 1 and 2.
Yeah.
Eyelid position, you are always describing with MRD1 and D2. Whether it is ptosis or in whatever situation you are talking, it should be MRD1 and D2. Right?
Yes, sir. Sir, I have mentioned along with the hurdles and IOP.
Hurdles is different. When you are talking of lead position, your MRD1 should come there. It's okay. We'll go ahead. Go ahead.
Conjunctiva, there's a mild congestion is seen.
Now, one more thing. In the history, two important things you did not ask, especially pertaining to thyroid-associated orbitopathy. What are they? In the history, number one, whether there is any pain, if the pain is on movement of the eyes or even without movement of the eyes. That's number one. Number two, is there any periocular edema or swelling, worse in the morning and getting better in the evening? Both these have points in the inflammatory score, because the treatment depends on the inflammation, right? Both CAS or VISA, whatever we talk of. Further, you have to ask these two in the history. Another important visual symptom that you have not asked is for presence of double vision. These are the three important points that you missed in the history. Okay, go ahead.
So anterior chamber, there's no, it's right eye, it's normal.
One more thing also. Here also you have to mention that there are inflammatory points for the lid, like lid erythema, lid edema, right? They are not there, you have to mention. Especially in the case of thyroid, not for a general case of proptosis. But here you have to mention, because you are talking about the inflammatory point and points for inflammatory score. For that reason. Okay. Conjunctiva, mild congestion is present. That's good. Then no chemosis. No caruncular edema. All these have points for the inflammatory score. All those things you have to mention in the case sheet in your examination. Okay.
Yes.
Right.
Cornea, it's clear.
Lids are over. Lids are over in the inspection. You did not mention about lid lag and down gaze. You did not mention about lag of thalamus.
There's a proptosis inspection I wrote separately, sir.
No, when you are talking this, you have to complete all these. Okay, that's okay. We'll come to that. Right. Because cornea clear. Okay.
Anterior chamber is having normal depth and normal contents. Pupil is normal size and reacting to light. Lens is clear. In the left eye, the uncorrected visual acuity is 6/6. He's reading 17/17 color vision Ishihara plates. Upper lid in the left eye, the upper lid is retracted, where the upper lid is covering 1 mm of the cornea. Conjunctiva is quiet, cornea is clear, anterior chamber having normal depth and normal contents, pupil normal size reacting to light, and the lens is clear. This is a slit lamp diffuser. Photos of the eyes.
Right.
Fundus examination, right eye, the media is clear, optic disc normal, cup disc ratio is 0.4:1, vessels are normal, the foveal reflex is present. In the left eye, the media clear, optic disc normal, cup disc ratio is 0.5:1, vessels normal, foveal reflex is present. Coming to the extraocular movement, the patient the patient is having mild restriction in the abduction of the right eye, sir. So, remaining all are normal. Extraocular movements are full and free in all direction except the right eye in the lateral position.
So, did you test for a diplopia?
Actually, he is not complaining about diplopia, sir. There's no complaint.
That's why I asked. There's no complaint, but did you test for that? In the exams, they'll ask you, did you test for it or not? When there's a motility restriction, you remember that many patients of thyroid orbitopathy have motility restrictions, but only some of them complain of diplopia, not everyone.
Yes.
Because it may be at the periphery of the visual field, and probably they are not bothered. Okay.
Yes.
That you have to take care of.
Yes.
Okay. Go ahead.
So in right eye, the palpebral
Right. Okay. Go ahead.
So in right eye, the palpebral fissure height is 12 mm, sir. Like the MRD one is 6 mm and MRD 2 is 6 mm.
Okay.
The Hertel's baseline 108.
We call it base reading, not baseline. 108. Okay.
Reading at 108. We measured the amount of proptosis, where we got the amount as 26 mm.
Okay.
We measured the IOP of the right eye. The intraocular pressure normally in primary case is 24 millimeters of mercury, whereas in up case, it came as 26 millimeters of mercury.
Why did you test in the up gauge?
So inferior rectus is most commonly involved in
in this, where is the motility restriction? In which gauge is the motility restriction?
The abduction, sir, right eye.
Then why did you, if there is a restriction in elevation, then you are looking at up gauge. When there is no restriction in elevation, why did you test for that? You have to do it for the abduction, because it could be a tight medial rectus, which is causing motility restriction in abduction. And for differential tonometry, you were doing it in the direction of restriction of ocular motility.
Yes.
Okay.
Yes, sir.
Why it increases? Explain.
So when there so generally the most commonly involved muscle is inferior rectus, sir. So when the patient is
I am asking, my question is, what is the importance of differential tonometry and how it affects in paresis and how it affects in restrictive motility disorder?
so when there is so in thyroid there is an enlargement of extraocular muscles with fibrosis, sir. So when the patient is looking in the up gaze, there will be blockage to the ovioscleral drainage, sir. So
where did you read?
Aravind FAQ, then
No, that's wrong. That's it.
And also when the patient is looking up, there's a compression on the globe, which rises episcleral venous pressure.
Yeah, that's because of the compression.
Yeah.
The eyeball is being, when the patient is looking up, there's a tight inferior rectus. I'm not talking of this case. If
Yes.
there's a motility restriction in the elevation, when the patient is trying to look up,
Yes.
the superior rectus is contracting. The inferior rectus, which is tight, is not relaxing, and the eyeball is compressed between these two muscles, and the IOP raises.
Yes.
In case of paresis, what happens? If the superior rectus palsy, when the patient is trying to look up, the inferior rectus relaxes. The superior rectus, which is paralyzed, has reduced tone. So the pressure exerted by both the muscles on the eyeball is reduced, and hence the intraocular pressure falls.
Decreases.
This is the mechanism of changes in the intraocular pressure in differential tonometry when there is a motility restriction.
Yes.
What is the other test to know whether the motility restriction is a paralytic or restrictive?
Force reduction.
Force reduction test or force generation test? Did you do force reduction test in this patient?
No, sir.
When there is a restricted abduction in the right eye, as you said, did you do a force reduction test?
No, sir.
No. So this patient had a proptosis of 6 millimeters in the right eye and 3 millimeters in the left eye, with no inflammatory signs, with normal vision. IOP is just at the borderline, 24 in the right eye and 19 in the left eye. Right?
Yes, sir.
Yes, go ahead.
Coming to the local examination, the head posture is normal, the facial symmetry is maintained. Coming to the Hirschberg corneal reflex test, the eyes are in orthophoric position. Coming to the proptosis inspection, this is a bilateral axial proptosis is present where the right eye is greater than left eye. The Hirschberg corneal reflex test is showing central reflex. Nafziger sign showing protrusion of the right eye greater than left eye is noted. So here's the Nafziger view test. In the inspection, we also go for Worm's view, which is showing protrusion of the right eye greater than the left eye. Then the protrusion is not increasing on any straining, bending, or coughing.
When does it happen? In which conditions that will happen?
So when it's bending orbital varices,
Yeah.
so the proptosis will get increased in the condition of orbital varices.
Okay. One thing here is when you are doing all those things which are not needed for a thyroid, I will put a question. Did you look for pulsations? You didn't mention whether you have looked for pulsations. Is it a pulsatile proptosis or a non-pulsatile proptosis?
It's a non-pulsatile proptosis.
You didn't tell me, you didn't look for that. How do you look for pulsations? How do you identify? In which way you will look at? And which investigation will makes it easier to document, notice it? For pulsations, you have to look from side, not straight and down. You have to look from side.
Yes.
Okay. Number two, if you keep a Shear's tonometer, it will be moving. The needle will be moving, oscillating.
Yes.
The pulsations will be exaggerated because of this delay.
Yes.
Or if you look at the Goldman's affiliation tonometry, as it is pulsating, you will be able to, it comes and goes, it comes and goes.
Yes.
You will be able to make it up. So recording of IOP is another measure of looking at and identifying pulsations.
Pulsations. Yes.
Okay, go ahead.
So in right eye on inspection, lid margin just touches the superior limbus and 1 mm from the inferior limbus, and the left eye 1 mm is covering the cornea. Temporal flare was present.
What is temporal flare and why it happens?
So temporal flare, mainly there is a congestion on the temporal side of the limbus, sir, because due to the lateral aponeurosis, lateral horn of the aponeurosis having a strong action than the medial horn, sir, which is well. The lateral horn goes through the lateral orbital retinaculum and the lateral tubercle, which is well defined. So any inflammation, adhesions, and fibrosis are more pronounced on the lateral side, and also the Muller's muscle activity, which is an involuntary muscle, is more pronounced on the lateral side, sir. So
it's more. So is it inflammation or something else? What is the lateral flare? Temporal flare.
temporal flare is actually it's the sclera which we are seeing is more visible on the lateral side than that of nasal side. It is the temporal flare, sir.
So what, to be honest, the better way of telling what it is the highest point of the upper eyelid is at the junction of medial and middle thirds. It goes up after a middle third, it comes down. But in temporal flare, the highest point moves away from the middle 1/3. It goes further laterally. So that is the lateral flare or temporal flare. It moves temporally. So that is the shape that is typical in TAO, thyroid orbitopathy, mostly due to the increased action of the Mueller's muscle.
Mueller's muscle. Yes.
Right. Okay.
The
lid light was present on down gaze. You have to measure it. How many millimeters on down gauge? Width of the palpebral aperture in down gaze. Also, you have to mention. Okay.
There's no variation of proptosis with bending forwards or with valsalva manner. Proptosis was non-pulsatile. There's no evidence of engorged or corkscrew vessels in the right eye.
Okay.
Coming to the palpation in both eyes, the orbital margins are intact. There's no local rise of temperature or tenderness over the eye. Insinuation of fingers was possible. Resistance to retropulsion was present. The proptosis was non-compressible and non-reducible. There are no thrills or pulsation felt. There is no change in proptosis with carotid artery compression or jugular vein compression. On auscultation in both eyes, no bruit heard in both the eyes. Coming to the summary, a 38-year-old male with chief complaints of protrusion of both eyes since 8 months. He was a known case of Graves' disease and now euthyroid due to anti-thyroid drug usage. On examination, right eye upper and lower lid are retracted and left eye upper lid retracted with Hirschberg corneal reflex test in the central position, which is suggestive of axial proptosis, which is greater in right eye and the left eye. So my provisional diagnosis is both eyes having axial proptosis where right eye is greater than left eye, probably due to thyroid associated ophthalmopathy. The clinical activity score is 2 out of 10, and the no spec score is no specs is soft tissue involvement present, proptosis is present, and extraocular movement involvement is also present. According to Ugoga classification, it comes under moderate to severe Graves of orbitopathy as he received methylprednisolone doses previously.
Okay. To be honest with you, with my experience, Ugoga classification is where Indians. Am I audible? I'm hearing certain sounds. Am I audible? Yes or no, please, somebody?
Yes, sir. Yes, sir.
Yes, am I audible? Right. Okay. I do not go for Ugoga classification for the simple reason that the way the Indians behave with thyroid orbitopathy is different from the Caucasians and the Europeans. Right? As per the Ugoga, a more mild it's less than 3 millimeters of proptosis. and with minimal lid retraction, 2 millimeters or so. Here you have a patient with 2 mm of lid retraction the right eye. Then proptosis is 6 and 3 millimeters, which goes to the moderate and severe orbitopathy. But the inflammatory score as of now is really, even 2 is only, CAS is, to my knowledge, 7 points, not 10 points.
Sir, it's a follow-up. I took the case at second presentation, sir. First presentation, he was active. So we sent the patient to the endocrine department for receiving IV methylprednisolone. Now he's just now the patient is on follow-up, sir, on the second week.
Okay, that's what I can understand from you. I prefer a visa classification, which was not mentioned here. You have mentioned about no spikes, which nobody does nowadays. It is visa and UGOGO. UGOGO is more common in Europe. Visa is more common in America and Canada. So I do the visa classification, I follow it. The advantage of visa classification is it tells you what to do at each stage. And do you have an idea about visa classification? Or can you do something? Can you explain a little about, speak on CAS score and UGOGO? I'm not interested in no spikes.
So CAS is a clinical activity score, sir. So this score will be taken in the first visit and the follow-up visit.
Yeah.
So first visit, we look for spontaneous orbital pain, gaze-evoked orbital pain, lid erythema and edema, and conjunctival chemosis and conjunctival congestion, along with the caruncular congestion, sir, caruncular inflammation. This is in the first visit, sir. So 1 out of 7, 3 out of 7, the 7 parameters are used in the first visit. So in the follow-up, we use the other 3 parameters where we look for the increase in the proptosis of greater than 2 mm and decrease in the extraocular muscle movement of greater than 8 degrees and decrease in the visual acuity of less than 1 line in the Snellen.
One Snellen line within 3 months.
Yes.
Within a period of 3 months.
Yes,
right. Since you do not have the score for the first visit at KGH, right? You can, I don't know how you went for 2 to 10. It's for you, this is the first visit. Okay. How about UGOGO?
So UGOGO,
staging.
Actually it is based on the activity and severity of the disease, sir. Activity is based on the inflammation and severity is based on the risk of vision loss and the quality of life. So there is a mild Graves orbitopathy, moderate to severe orbitopathy, and sight-threatening Graves orbitopathy. In mild Graves orbitopathy, there is a minimal impact of the life, where there is a lid retraction of less than 2 mm and mild soft tissue involvement and proptosis of less than exophthalmos of less than 3 mm and no corneal involvement which is responsive to lubricants and there is no diplopia here. So the mild case we can go for lubricants and topical tablet selenium and head end elevation. So this is the treatment we'll give. And for the moderate to severe Graves orbitopathy, so it is suggestive. So it is moderate to severe, having a sufficient impact on the daily life. So it is suggestive to give immunosuppressant when the disease is active and go for any surgery, orbital decompression when the disease is inactive. So here there is a lid retraction of greater than 2 mm and there is a mild to moderate soft tissue involvement and a proptosis and exophthalmos of greater than 3 mm and constant or not inconstant diplopia. So we can go for whether the disease is active or inactive, we can go for the treatment. If the disease is active, we'll go for IV methylprednisolone, giving 500 mg per week for the first 6 months and the 250 mg per week for the next 6 months. So we'll look for 12 months, sir. So if the disease is still not progressive,
not 6 months, not 6 weeks.
6 weeks and 6 weeks, 12 weeks, sir.
Right.
If the disease is not responding, we'll go for aggressive therapy like giving IV methylprednisolone for every 3 days. Despite giving this thing, still the disease is progressive, we'll go for orbital decompression surgeries. We'll go for orbital decompression surgery.
Orbital decompression when the vision is normal.
First, if no, sir. If the patient is not responding, we'll go for alternate glucocorticoids, like alternate to glucocorticoids.
Immunosuppressants, alternate
Yeah.
immunosuppressants you have.
Like
to take.
cyclosporin A, methotrexate, tocilizumab, rituximab,
Rituximab.
with oral glucocorticoids.
Don't tell Tepezza, right? Teplizumab, it's not available in India and it's prohibitively expensive. But there's the only drug that reverses the disease, nothing else. No diseases.
Yes.
Okay, all right. So the class that I'll be taking on thyroid orbitopathy, I'll be taking a webinar, probably 3 weeks down the road. Then I'll tell you about the visa classification and how visa classification differs from UGOGO.
Yes.
I prefer a visa classification because in India, I see so many patients with 5 to 6 mm of proptosis, without diplopia, without inflammation, without pain, nothing else. Comfortable. They come to you because somebody says that the eye is looking right, or in the photograph it looks bad.
Yes.
Where do you put in? Which class you will put it? Mild or moderate?
I didn't get you, sir. Sorry.
No, it's difficult to put it, Nana.
Yes.
Because mild is less than 3 millimeters. Here I have a patient with 4 millimeters. 4 millimeters is moderate to severe, but no inflammatory signs.
Yes.
Absolutely quiet eye. His lifestyle is wonderful, going on very well.
Yes.
Where to put it? Because these are not there in visa classification. We look at each independent endpoint of the disease, and based on that, we give the treatment. That's how it differs. The second is that dosage is different in visa classification. It's much more aggressive. We start with 1 gram IV methylprednisolone on alternate days for 3 injections, then review and then disable. Now, just for the discussion's sake, what are the various treatment options that are available in thyroid orbitopathy, and when do you use them? Tell me.
The first most important is steroids, sir. Thyroid orbitopathy.
Like immunosuppression with steroids. Right.
First
Immunomodulation. Great. Okay. When do you use? Do you use in every patient?
No, sir. When the disease is active, we use IV methylprednisolone, sir.
IVM. Okay.
IV methylprednisolone 500 milligram per week. Up to 6 weeks, and 250 milligram per week up to 6 weeks. For about 12 weeks, we have to give IV methylprednisolone, sir.
Okay.
If he's not responding, we'll go for aggressive therapy. IV methylprednisolone every 3 days. 1 gram of IV methylprednisolone every 3 days we have to go for, sir.
That's what visa classification does for every patient. Starts as aggressive treatment and they respond. Okay.
If it is responding, okay. If it's not responding, I'll go for alternate glucocorticoids, oral glucocorticoids along with cyclosporin A.
Not responding.
Not responding.
Then what will you do?
Cyclosporin A 5 mg per kg.
Not responding to medical treatment. What will you do? What are the other alternative modalities of treatment that are available?
Medical, surgical, sir.
in between radiotherapy.
Radiotherapy, yes, sir.
So if the disease is active and not responding to medication, then you can think of radiotherapy. Similarly, radiotherapy can be used in case of if the patient has an optic nerve compression, how are you treating it?
If there is an optic nerve compressive optic neuropathy, we'll go for surgery, sir. It's an
Straight.
indication for surgery.
Straight. Surgery is a very difficult manner with lots of complications. Right. So you have to decompress the orbit. The first thing is medical decompression. Medical decompression with IV methylprednisolone at a dose of 1 gram on alternate days for 3 injections, that is 3 grams. And if the patient is responding, follow it with a dose of IVMP 1 gram per week for a total dose of 8 to 10 weeks, by which time the optic nerve recovers in most of the cases. Right? Once it has recovered, then you can give radiotherapy with linear accelerators at a dose of 200 rad per sitting, 5 sittings a week for 2 weeks. That is a total dose of 2000 rad along with steroids. Oral steroids at a dose of 40 to 50 milligrams per day and tapered over a period of 4 weeks. On the other hand, with the IVMP, if the disease is not slowing down, the optic nerve compression is worsening, then we'll go for surgical decompression. Depending on the amount of proptosis, it could be 1 wall, 2 walls, or 3 wall decompression, along with excision of intracorneal fat, ranging from 3 to 5 cc of fat excision will be done. That is how you will do when there is an optic nerve compression. Once it has recovered, then you put the patient on radiotherapy. The advantage of radiotherapy is in about 85% of patients, the disease stabilizes and will not progress. Right? So what is the normal duration of the disease active phase? And what is that curve called?
Randall's curve, sir.
Yeah, how many months it is? 18 to 24 months. So we'll take 24 months as the endpoint, and you have to follow the patient for 24 months.
Yes.
Okay. Then, with radiotherapy, in 85% of the patients, the disease stabilizes and will not progress. That is why you are preventing a recurrence of compressive optic neuropathy by giving radiotherapy. And radiotherapy also has a role in treating, apart from the inflammation, the compressive optic neuropathy also. It is, of course, contraindicated in diabetics and patients less than 35 years of age and patients with hypertensive retinopathy. In these conditions, the radiotherapy is contraindicated. Otherwise, radiotherapy with the linear accelerators has an important secondary line of management in compressive optic neuropathy post response to steroids or surgery, and inflammation not responding to steroids. You can think of Radiotherapy. Okay. Then tell me, how do you diagnose compressive optic neuropathy clinically?
So basically, the first thing we have to do is vision, sir. So when there is a compressive optic neuropathy, there will be a reduced vision as well as color vision. When look pupil and coming to the pupillary examination, there will be a presence of RAPD. And coming to the fundus examination, we can look for optic disc edema. Initially, optic disc edema and choroidal folds are seen. Laterally, there will be on a later phase there will be optic atrophy.
You don't see choroidal folds. Choroidal folds will be with the intraocular mass usually. Already normal. Intracorneal mass, you will find choroidal folds. Not in this. Paradox. And what else? Visual fields. And in what investigation shows optic nerve compression? Where does it occur? In which part of the orbit it occurs?
Intraorbital portion of the optic nerve, there will be compressions.
In which part? The obvious intraorbital part only. Is in the anterior third, mid third, or posterior third?
Maybe mid-third.
It is apex,
Upper.
apical compression, posterior third. If you see the CT scan, the medial wall is straight like this, the lateral wall is at 45 degrees, right?
Yes.
So anteriorly, there is a lot of space. Posteriorly, the walls are closer.
Yes.
And all the recti muscles take origin at the annulus of Zinn, which is around the orbital canal. From there, all the muscles, and between the four recti, the optic nerve goes. So when the muscles are enlarged, they compress at the posterior third of the orbit. So this is called apical compression. And sometimes it can compress the superior ophthalmic vein also, and all they, so that the superior ophthalmic vein is bit enlarged. So here you see the muscles are enlarged, sparing the tendons. Right. So what are the various conditions in which the extraocular muscles are enlarged?
So the main differential diagnosis is idiopathic orbital inflammatory disease. So here it's a pleomorphic cellular infiltration of the orbit. It's an inflammatory variant where it occurs in all autoimmune diseases like SLE and all, where it can occur in variants like
How
dacroid.
do you differentiate?
So in the radiographic part, in the imaging, there will be enlargement of extraocular muscles along with the tendons in the idiopathic orbital inflammatory disease.
What else?
It's a pain orbitopathy, sir, whereas
no, looking at the CT scan, in the exams, I'll put two CT scans. I'll say one is thyroid orbitopathy, the other is orbital inflammatory syndrome. Which is which? I want you to identify.
There is a ovioscleral enhancement also present in the IOID, sir.
Contrast enhancement will be there. Because it's active inflammation, there will be contrast enhancement. The muscle belly along with the tendon is involved. Single lateral rectus muscle involvement never occurs in thyroid disease. I don't know the explanation, but it's an observation. I did not come across why it happens so. If you see a single lateral rectus muscle that is enlarged, be sure that it is not a case of thyroid orbital. Right. Sometimes the fat can also be enhanced and the optic nerve can be enhanced. Another important condition in which all the extraocular muscles are enlarged is carotid cavernous fistula. In carotid cavernous fistula, the muscles are enlarged, superior ophthalmic vein is also enlarged. In thyroid orbitopathy, extraocular muscles are enlarged, superior ophthalmic vein is also can be enlarged. How do you differentiate both? Looking at the CT scan. Primarily, look at which structure is involved. In thyroid, it is the muscle that is enlarged, primarily involved. Isn't it? So the muscles are grossly enlarged, whereas the superior ophthalmic vein enlargement is much thin, much less. Whereas carotid cavernous fistula is primarily a vascular disease.
Superior ophthalmic
The
vein.
enlargement is very big, very thick, very big. And the
Compared
muscle
to
enlargement is there, but it is not as great or as much as in thyroid. Right. So that's depending on the basics. So what are the various investigations that you will ask for it in thyroid?
so they can blood investigations and imaging, sir.
Not imaging and visual fields. Visual fields, compressive article neuropathy, you have to get the visual fields both for white and color object. Okay, red and green colors, color visual fields. And in case of in imaging, I prefer a CT, some prefer MRI, I prefer a CT scan, a plain CT scan, where you will see the what are the changes that you find in the CT imaging.
Basically in the Coca-Cola sign, sir.
First is enlarged extraocular muscles with
Enlarged
sparing of the tendon.
Yes.
Number two, maybe Coca-Cola sign because of the excavation that occurs in the medial walls due to bilateral thick medial rectus muscles. Number three, increase in the volume of fat, which you can see fat prolapsing through superior ophthalmic and inferior ophthalmic fissures. And with this, the lacrimal gland may be pushed forwards. It's not enlarged, but the lacrimal gland may be prolapsed or pushed forwards. These are the things that you see in the CT scan. Okay. And as I said, superior ophthalmic vein may occasionally be enlarged. And the muscles that are enlarged are usually multiple muscles and usually bilateral. Even if there is a proptosis unilateral, the other eye shows a little bit enlargement of one or two muscles. And as I said, single lateral rectus muscle enlargement is yet to be described in thyroid eye disease. Is the inferior rectus followed by medial rectus, then superior rectus and lateral rectus. That is how it is. Somebody said the tip the other day, I am slow. Inferior, medial, superior, lateral. Somebody said that this is the tips are how I remember. I am slow. Right. So when a patient of thyroid eye disease comes, you should be able to stage it and then plan management. Okay. So among all the signs and symptoms that I have talked about compressive optic neuropathy, which is the most sensitive? You said visual acuity, color vision defect, then RAPD, optic disc fundus changes, apical compression in the CT scan.
So color vision is more sensitive.
Color vision is the most sensitive. Why not defective vision?
Because the axons passing through the macula are more sensitive. So,
Defective vision can be due to the other factors also, other causes.
yes.
Right.
Mm.
Then why not RAPD?
So, RAPD exists when the entire nerve gets
Not entire nerve. If it is bilateral symmetrical nerve compression with vision loss, there will not be RAPD. Relative afferent pupillary defect, RAPD, occurs only if it is unilateral or bilateral asymmetrical involvement.
Yes.
If there is a bilateral symmetrical involvement, because thyroid disease can be bilateral, so there are occasions when RAPD may not be present, even in the presence of optic nerve compression. Fundus, subtle changes you may miss. Optic nerve compression. So CT scans were shown to multiple orbital surgeons to predict whether the patient had optic nerve compression or not. Nearly 10 to 15% of them fumbled. That is why the simplest, easiest, and which happens within a minute and which doesn't cost is color vision. For every case of proptosis, make it a habit to do the color vision test. Okay? Right, you have done a fairly good job. But the things that I have said are the things that you have to make a mention of it in your examinations, so that you will score better, much better than what you have done today. Okay?
I'll edit, sir.
Right. Okay. Thank you.
Thank you, sir. Thank you.
You have done Hertel's, right? With a base reading of 108 something you said.
Yes, sir.
Why should you mention a base reading?
For the follow-up, sir. So every time at 108 will be taken for the measuring the amount of proptosis.
Right. For comparative values, exophthalmometry, you have to do it only with the base reading constant in our case, in that case.
Yes, sir.
The first reading with whatever base reading you have taken,
Yes, sir.
other you have to do the same base reading.
Yes, sir.
Okay?
Yes, sir.
Right. Thank you.
Thank you, sir. Thank you so much, sir.
Any questions or anything from others? They're welcome. So you have differential diagnosis and other things to present. Please go ahead. I'm sorry.
So my differential diagnosis is cavernous hemangioma, cavernous sinus thrombosis, idiopathic inflammatory pseudotumor of orbit, metastasis of the orbit from the primary sites, orbital cellulitis, keratoconus fistula.
So how do you differentiate each one of them from your picture, from this?
So cavernous sinus thrombosis mainly it can occur in this age, but it will be bilateral, sir, and the patient will complain of headache, nausea, vomiting. He won't
That's the case.
be able, sir.
You won't receive phone call.
Hello.
Now, if any case comes, what should I do? Like, I'll call Karishma, ma'am.
Cavernous hemangioma. Cavernous hemangioma, how do you differentiate? Cavernous sinus thrombosis has pain as well as severe motility restriction and is usually bilateral and severe motility restriction bilateral, with the lateral rectus being affected in both sides. Cavernous hemangioma. Hello, are you there?
Am I audible, sir?
Now you are audible, yeah.
Yes.
Cavernous hemangioma, how do you differentiate?
Cavernous hemangioma is having female preponderance, and it is detected by chance, sir. So
No, cavernous hemangioma is a slow progressing unilateral axial proptosis. Bilateral is very, 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 very unusual. Right.
yes,
Number two, the duration will be much longer.
yes, sir.
Will not have lid retractions and lid lags and other things. That's how we differentiate a cavernous hemangioma.
Yes.
Idiopathic orbital inflammatory syndrome. Don't say pseudotumor, please, for heaven's sake.
So it is there is no gender preposition in the pseudotumors, the idiopathic inflammatory orbital disease, sir. And it is a painful orbitopathy, sir.
Yeah, pain is the major and acute to subacute presentation with pain, whereas it is a chronic presentation in this patient and bilateral. Idiopathic can be still unilateral more often, but it can also be still. But the most important thing is pain, redness with motility restriction and
Yes.
diplopia.
The painful orbitopathy, mostly it's unilateral, and there will be elevation of ESR, sir. Since it's inflammatory condition.
Yeah. Then metastasis
Metastasis,
do not come under differential diagnosis at all for this condition. Metastases are very fast, very rapid, right? You do not have 3 to 6 months time. Usually, majority of patients with orbital metastasis die within 6 months. Majority of the patients die within 6 months. Okay. Such a fast growing with motility restriction, pain and all that. So bilateral metastasis are also a bit rare. I have seen only one case with bilateral metastasis. It's quite rare. But metastasis, and that patient died within 10 days. Right. Orbital cellulitis, again, will not come under differential diagnosis for me at all. Because it is, again, more often than not unilateral, severe pain. Right. Yeah, this patient right now has, even if he has a mild inflammation, bilaterality is one thing that is important. CCF,
it's having pulsatile proptosis, sir, having bruit and thrill.
yeah.
That the patient is having non-pulsatile proptosis.
And also caput medusae, conjunctival chemosis.
Yes.
Right? Motility restrictions.
Corkscrew, epipulbar.
That is a caput medusae. Caput medusae is the same. So without them, you cannot think of cavernous fistula.
Mostly sixth nerve palsy is.
Sixth nerve palsy, those things also you cannot, because in case of sixth nerve palsy, the primary position, the eyeball will be in esotropia. Here, the eyeball is the primary position in this patient, right? So sixth nerve palsy will not be there. In keratoconus cavernous fistula, yes, there could be sixth nerve palsy, right? Along with severe caput medusae, congestion, chemosis, pain, symptomatic blue, pulsatile proptosis, raised intraocular pressure, CT, and fundus showing dilated vessels and all that. None of them are there. So you can easily differentiate it from CCM. Okay. Right, Amma.
Thank you, sir.
Good presentation, a good case, an important case for you in the examination. In my class of the PAO, I'll be concentrating mostly on visa classification, which I follow rather than you go and other things. I'll give my view of thyroid associated orbitopathy. Okay? Right. Anything, any more slides? Is it Is it over? I think Madhu, it's over.
Sir?
I think it is. Presentation is over. And
Yes, sir.
unless somebody wants to talk.
Yeah. I
Yeah,
think from
yeah.
anybody of the faculty or
Faculty
students wants to
can
interact
discuss.
with sir, this is the time.
Yeah,
And
yeah.
after that we can close. Sir, next week we'll start off with the proptosis, sir.
Proptosis, yes, with proptosis. Orbits.
Okay, sir. Okay, sir.
Next week we'll start with orbit, evaluation,
Shyam.
efficacy from there. Right. Anybody wants
Shyam,
to
are you
any
there?
in the faculty?
Okay. Any of the faculty want to interact with sir?
Or interact and make their comments about this case presentation and all that.
Yeah,
And with what I said. If you agree if you disagree, I'll be happy to discuss, and I will be happy to agree to disagree also sometimes.
So thank you very much, sir. It's really refreshing for us also. You are a teacher for teacher.
Thanks so much.
So thank you very much,
There are
sir.
many
Very,
points
very excellent,
which I have
excellent,
learned
sir.
today.
We learned many points, sir.
Thank you so much.
Sir, we'll end the session.
Oh yeah.
Thank you, Amulya.
Thank you, sir. Thank
You have presented wonderfully, and presenting before sir is a good opportunity. I think you had a great learning experience because sir has told lot of points. It will
Yes,
be
sir.
of lot of value for your final exam. Your exam going, no?
Yes, sir.
Yeah.
These are all should improve your performance in the exams, Nana.
Exactly.
If the same comes, if the same case comes for you,
I
Yeah.
don't think
highlight.
anybody can ask questions beyond this.
I'm very much honored, sir. So I have missed so many points in my PPT. So I will.
Yeah. So it is a very good active learning for you and passive learning for all the others who have attended.
Yes.
Thank you so much. Good night. Thank you, sir.
Thank you. Good night.
Right, sir. So
everyone.
next
very
week
much, sir.
again we'll meet with the
With
continuation
my
of our
presentation.
series,
Yeah,
proptosis.
I'll be starting with proptosis next week.
Yes, sir. Thank you, sir.
Right, thank you.
Yeah.
Bye.
Good night.
Bye.
Good night, all of you.
Very good to know.